to when to there is no protocol as to when to intervene depending on the Qmax. However, if the patient is having significant symptoms or Qmax goes below 10, then we decide to intervene in some way in our institution.
So what intervention you do at that time?
Sir, I can get an investigation.
At 6 months, suppose patient is having this sort of problems, dysuria, slow, again weak flow,
yes, sir.
Qmax going down, then what will you do?
I will, sir, once again get a routine urine and culture to rule out an UTI. In the absence of a UTI, I will do an RGU followed by an urethral assessment and dilatation necessaries.
Dilatation is, yes, you do RGU. Yes. And after in RGU, if you see something not normal, then what investigation you will do next?
Sir, I will do an.
You will have to assess the urethra then.
I will do an urethral assessment by urethroskopy, and at the same time, sir, if I find any shorts, usually the problems associated are a short, flimsy stricture at the
that can be dilated
of the anastomosis. So we usually dilate the stricture at the same time.
So this is cystoscopy or urethroskopy. Okay. Next, what will you do? This is up to 12 months you followed up. Then every yearly you follow up the patient.
Yes, sir.
Yes.
Okay, Doctor.
This, yeah. Tell.
Dr. Qasim, if immediately following catheter removal, there is a penile swelling. Okay. Sumantra or Qasim, anybody can ask. Immediately after catheter removal, the patient is voiding and there is a history of penile swelling. What you will do?
Sir, if the patient is having an SPC in situ, I will immediately connect the SPC and put the patient on antibiotics and follow up the patient. There is probably a site of leakage in the site of the anastomosis, so I will give it more time to heal. I will not attempt recatheterization.
So any investigations?
Immediately at this time, sir, I will not perform any investigation.
You will not do an MCU.
Okay, sir, I can do an MCU at this time. Yes, sir.
And after that, what? Suppose the MCU shows a urinary extravasation or there is a fistula, then what you will do?
So I will keep the urine diverted and then follow up the patient after an interval of time.
Diverted for how many days?
Sir, I will keep the patient diverted for at least 3 months, sir.
3 months?
Sir, in the event of a fistula, having diagnosed a fistula in the immediate postoperative period with an MCU, I would like to divert the urine for at least 3 months, sir. Preferably, I can even divert it for a further period and then reassess.
What are the recommendations?
Sir, I am not aware of these recommendations, sir.
We generally keep the patient diverted for 2 weeks and again do a MCU. And if again the MCU is showing a urinary fistula, then generally they will require a review. If Bagji sir has any comment,
you will have to give rest after 2 weeks of MCU. If again you see extravasation of urine, then you will have to give rest to the urethra for a little longer period.
Sir, Dr. Qasim, if the urinary fistula is not healing, then what are the options?
Sir, if urinary fistula
is not healing, after 2 weeks of rest, again the fistula is there. Again 2 weeks of rest, fistula is there. Then what are the options? 1, 2, 3. Actually, it should be in what are the options?
Urinary fistula is not healing, then we rest the urethra for and drain the SPC for 3 months. Then we again
fistula is not healing after
with this,
Dr. Qasim, you like to rule out something. You need to think why this patient developed fistula. That is the main thing. Otherwise, you have given rest to the urethra for 2 weeks. It should have been healed or improved. Even after 2 weeks or 4 weeks, the patient is not improving. That means there is something else which you are missing. What are the things you might be missing?
Sir, we might probably be missing a meatal stenosis associated with this disease. Persistent meatal stenosis can be there, or
Anything else? One is any distal obstruction you are missing, or
Yes.
there may be some focus of infection which is preventing the fistula to heal. That is the two things you should investigate whether this patient is having this or not. Once you have ruled out these things, infection and distal obstruction, then you should think of repairing the fistula. What are the options of repairing?
So, sir, this becomes a complex fistula. This becomes fistula with stricture. So, firstly, sir, I would like to wait for 6 months from the initial surgery for the entire induration and surgical site to heal. After that, I would like to reevaluate regarding the site of the fistula, the size of the fistula, and assess the associated the remaining part of the urethra after surgery, and then plan my surgery, sir. Sir, if it is a small fistula uh, in the
So now I will give you two options.
yes,
One, in first case, there is all the urethra is normal. You can easily pass the 16 French catheter, and there is a 1 centimeter fistula. What you will do?
sir, 1 centimeter fistula in the penile urethra, sir.
Yes, opening ventricle. You can see the catheter getting passed. There is a 1 centimeter or a 0. Or a 8 mm fistula. What you will do?
Sir, I will have
Sir,
to plan. Yes, sir. I will have to plan regarding repair of this fistula, sir.
You just go for the pointed answers. Give me a pointed. What you will do? What are the surgical options?
Sir,
It is clear. All the urethra is normal. Only 8 mm fistula.
Sir, I will
Of a
deglove. I will, sir, deglove the urethra, identify the site of the urethra, and then close the urethra transversely and put in an overlying vascular graft to protect the
Overlying. That means you want to put it again ventrally on a penile urethra.
Sir, I will do a repair as we do a repair in case of a hypospadias fistula repair. So, sir, I will do a circumcoronal incision, deglove the penis, identify the site of the urethra, and then put in either preputial vascularized inner preputial vascularized graft to bridge the defect, or a
That
primary.
is called as flap, not graft.
Yes, sir.
And if there is an associated stricture, distal stricture is there, then what you will do?
So then this becomes a complex stricture associated with fistula. I would.
Is there any classification like simple stricture and complex?
Complex strictures are considered to be strictures associated with either.
Is there any classification for the simple and
classification?
Okay.
Yes, I don't
think there is any classification. Anyway, now this is a stricture with fistula and a distal fistula. So now what you will do?
Sir, I will do a plan for a second surgery, but this time I will plan for a multi-stage surgery. I will do a first stage laying open of the fistula, and then second stage retubularization.
Retubulation with what?
Yes, sir.
Retubulation with what?
Sir, if the urethra associated with the stricture is very narrow and the urethral plate is unhealthy, then I shall consider excision of the unhealthy tissue in the first sitting, along with putting either split skin graft or a buccal mucosa graft, depending upon availability of tissue. And in the second stage, sir, I shall retubularize the urethra and put in an overlying vascular graft.
And when we are doing it, like sir said about a SOPA inlay, when you are spatulating the healthy urethra, how much you should spatulate?
Sir,
Sir, SOPA you will be spatulating healthy urethra, or you won't be spatulating?
Yes, sir, I will spatulate the urethra. So the ideal case scenario, my entire urethral width, including the BMG interposition.
My question is very specific. When you are laying open, when you are spatulating the healthy urethra, how long?
Sir, it should be 2.5 to 3 centimeter long. The entire urethral plates should be 2.5 to 3 centimeter long. so that after retubularization, we get at least an urethra that is more than 24 frames.
No, I'm not talking about the width. I don't think you got my question. Anyway, I think we
But I
should
did not
proceed.
understand the question.
Pushkar sir. Okay. Pushkar sir. Then continue. Pachi sir?
Yeah. How will you manage the fistula? So when you want to manage the fistula, when you want to treat the fistula, after operation, there is a fistula has taken place.
Sir, I will rule out distal obstruction. I will rule out presence of any associated infections, foci, and presence of any other foreign body that might be leading to persistence of the fistula. And then assessing the viability of the tissues in the penis, then I will plan for further surgery. In this case, if it's a small fistula, I will go for degloving of the penis, followed by primary repair of the fistula and put in an overlying vascularized tissue, superimposing tissue over the repair of the fistula.
What is the local vascularized tissues available?
The available tissues are preputial, inner preputial graft is, yes, sir, inner preputial graft can be placed.
Do you really put a graft or you put a dartos?
No, sir, dartos. Sorry, sir, I'm very sorry. Yeah, it's a dartos.
Second, one and
Tunica vaginalis flap.
The vaginalis can be placed.
Okay. Next, I will show the video of this, very short, the 5 minutes I will complete. How this operation was done, I will show. So, this is the urethroscopy with uretroscope. You can see the penile and bulbar urethra. This is the verumontanum. So, proximal part is normal. You make a very small incision in the perineum in the midline. I'm just going a little fast. Oh, sorry. Oh. So, this is the incision. After that, you superficial fossa. You incise the superficial fossa in the midline. Then this is the deep fossa of the perineum. The other name was the Gallaudet fossa. It is the overlying fossa of the urethra. Then you apply the retractor with hooks. And now you dissect out little more. And you hold the urethra with Babcock's forceps. And you go more distally and cut the overlying urethra, fossa overlying the urethra. I am going a little fast. So, as you go, you change your Babcock's forceps and pull the urethra down. Okay, this is you hold the urethra like this and you cut the overlying Gallaudet fossa. So you can see this is the glans penis is coming now. You cut overlying fascia more. Now change the position, pull little further. Now you hold at the glans penis and entire urethra will come out in front of you through the perineal wound. So 2.5 centimeter perineal wound, you can do the surgery. So from the meatus to the proximal bulbar urethra will be visible in front of you, and you can do whatever surgery over the urethra through this perineal wound. So long segment urethral stricture, this is the one of the good technique in a single stage repair. you can do through perineal incision. So this is little bit of what is the dartos layer being mobilized overlying the urethra. Next is you take stay sutures over the urethra on both sides. Now you make incisions over the urethra in the midline. This is called dorsal sagittal. Dorsal and ventral sagittal urethrotomy. This is ventral urethrotomy in the midline. You open the urethra. This is the 5 French ureteric catheter, so that you do not cut over any false passage. This catheter is will guide you. This is good to identify the urethra. So this is the way you cut and take few more stay sutures, and now you calibrate both distally as well as proximally to see the integrity of the urethra. Okay, now you do the dorsal urethrotomy in the midline. This is dorsal urethrotomy in the midline. You mobilize the urethra on either side. There should be sharp dissection. This is the way you cut the urethra. You can see the tunica albuginea is coming. So you can see the measurement. Now we're taking the measurement, more than 1 centimeter bed is made, and this is the buccal mucosal graft. Actually, the both ends should be elliptical. Okay, I'll make on the process of fixing it. 3 layers fixing, 1 in the midline. See, midline continuous suture. So this is continuous suture with 50. PDS, and this is the cutting needle. We take cutting needle because the tissue is little tough. So the cutting needle is always a better choice. So you cut make it elliptical. So the same way you fix the other side, and you just after fixing the quilting this thing buccal mucosa, you again see the integrity of the urethra. Now you see it is more than 1 inch. Now you put a 16 French or 14 French celastic catheter into the urethra, well lubricated. Now you close the urethra. This is the closure of the urethra. And to reinforce this thing closure line, you take the dartos layer, close the dartos layer with a continuous suture, and you just push the penis inside, and you can see this is very small defect in the perineum. Thank you very much. How to make it off? Stop share. Okay, Professor Devanshu, we have finished our first case. So do you want to comment on this? Hello, make it unmute. Please make unmute.
No, Dr. Bakshi, it was complete. I think we should go to the next case by Dr. Rohit. We'll be discussing a case on PFUDD. Dr. Rohit, you can share.
Sir.
Hello. Hello.
Yes.
Hello. Hello.
Hello.
Dr. Maji speaking.
Yes, sir.
As we know that inflammatory, particularly lichen sclerosis disease, progressive disease, and by doing treatment of stricture, you cannot prevent that progression. In long year follow-up, patient may develop extensive disease, and how will manage this extensive disease?
Maji sir, our
Hello.
second case, I want to present on case on lichen sclerosis, and we'll discuss
Okay.
lichen sclerosis on that.
Okay.
So should I start sharing the screen?
Yeah.
So I think it is visible.
Yes. Dr. Rohit,
Okay.
you can continue.
So it will be a short case presentation. Who is the student that will be coming? Dr. Deepu?
Yes, sir. I'm here, sir.
Okay. So the case goes like this, that a 23-year-old male boy has a history that he was hit by a tractor. There's a runover history is there by a tractor a year back. And he noticed that he went into a retention with blood at the meatus, for which a SPC was cited at the local hospital, and he had no associated injuries, like no laparotomy for a visceral injury was there, or any orthopedic treatment, or any hardware was inserted, or any traction or weights were used. So it was a clear-cut case of a road traffic accident followed by a detention for which a SPC was cited. And following that, he was not able to work. He even doesn't passes a drop of urine when he passes stool. There is no any significant surgical or medical history in the past, and he doesn't have any history of erectile dysfunction. So with this history, I will come to the examination. Examination by and large is unremarkable, except that there is a suprapubic catheter in situ.
Dr. Rohit, just a minute. So this, since this is an exam, so we should ask the students, starting from the emergency scenario.
Yes.
If he is called in an emergency, the patient with the accident, and what he should do starting from the emergency. Okay, what he should see, what he should ask, all those things. To start with those things.
Okay, so if suppose you are at the casualty medical casualty as a surgical officer in the casualty, and the patient comes with a history like this, run over by an accident and a palpable bladder with the blood at meatus, what are the things that you will see, and what are the things that you will?
Sir, in an emergency situation, after a road traffic accident, in any trauma, first we'll assess the vitals of the patient, sir. What is his pulse and BP, whether he is vitally stable or not. And
Yes.
after that, I will perform my examination, that per abdominal examination, local examination of the perineum, the penis, and the meatus. And if the situation permits, I can do a DRE also at that point of time. And if the bladder is palpable and if the patient is stable, I would preferably straightway go in putting a SPC.
Sure. So, is there any role of primary endoscopic alignment?
Sir, it says that it will improve the later outcome, but in an emergency situation, and if bladder is palpable, I would rather prefer not doing any other procedures, or rather doing only SPC will save my time as well as the patient time in emergency.
Is there any rule of doing a primary RGU or a primary catheter placement?
Sir, it is said that doing a primary catheter will help in forming less fibrosis, and on later date the repair will be easier.
When you will put a primary catheter?
Sir, we may attempt, a gentle attempt may be taken.
Straight away you will attempt, or will you do some investigation?
Sir, RGU can be done, but it's not recommended in emergency.
No, it's recommended. See, in an unstable patient, you don't do RGU.
Okay.
You simply put a catheter, suprapubic catheter. If a patient is stable, okay, you will have to stage the injury. So in that situation, if the patient is stable, then
Yes.
definitely you can do RGU. And by RGU, you can grade the injury, isn't it?
Yes, sir.
So after seeing the RGU, what next step you will do?
What you will see in RGU, which will suggest that you can put a catheter.
Sir, whether we'll see the continuity of the anterior urethra, whether the dye is going into the bladder or not.
No, you don't see the continuity of the anterior. Yes, you can see a thin streak of dye which is going into the
Yes,
bladder that is suggestive of a partial injury or a stretch injury where you can put a catheter. Okay, so your policy is that you put a suprapubic catheter and then you do a delayed primary excision and primary anastomy.
Yes.
So, okay, anyway. Now, suppose the patient comes to you after 4 months. So, what are the history that you will take?
Just one thing to Dr. Tipu.
Sir.
So suppose you have decided you do not have any facilities for doing RGU. You see the patient is having a palpable bladder. So you are called for a SPC. So can you tell me the steps and what is the exact site you want to do a SPC in this patient?
Yes.
Sir, the first priority is in an emergency situation, I will see that whether the bladder is full palpable or not.
Palpable, okay, fine.
If the bladder is palpable, I will identify the symphysis pubis and I will 2 finger breadths from the symphysis pubis in the midline. I will.
Why you want to do a SPC 2 finger breadths above the symphysis pubis? What is the idea?
Sir, this is for our further 2 things it will serve, sir. First, I will be sure that I will be entering in the bladder. Secondly, while doing repair, the site will help me in putting antegrade boogie while doing a repair.
Is it 2 finger breadths above or something else?
Sir, actually it is said high midline SPC, sir.
Yes.
What is high midline?
So as far as the safe permissible site I can reach.
How far you are safe? What is the anatomy behind this?
Okay, the question, sir, is asking what are the structures that you can damage?
Yes, sir.
While doing a SPC.
I may enter the, if I'm not in the midline laterally, I can enter the peritoneum, or even in the midline if I'm too high and the bladder is not palpable, then I can enter the peritoneum and injure the bowel, sir.
The bladder is palpable. Sir is asking very clear question. What is the exact site?
See, it is approximately at the midpoint between the symphysis pubis and the umbilicus. Because if you go by the peritoneal reflection in a full bladder,
yes,
that is the area. Below that, the blood, the intestinal content should not come. So you can go up to the midpoint of symphysis pubis and the umbilicus. So what happens if you do a SPC way down, just 2 fingers width above the symphysis pubis, and you have a very bad stricture, bad PFI, you may not be able to put your scope through the antegrade scoping. That is the idea of putting a high SPC in PFUDD versus a patient who has a anterior stricture. You can do it's very low down also. Okay, so in exam you should not say 2 fingers. You should say as high as possible, approximately between the midpoint of symphysis pubis and umbilicus. Okay. Don't get confused. Okay, then.
Can I tell one thing? Hello.
Yes, yes.
In our institute, we have made a rule that any SPC to be done under ultrasound guidance, because easily available. Ultrasound is nowadays in the emergency departments available, in our departments available. So we are doing ultrasound guided SPC in all cases to be in the safer side.
Yes, that should be the case. I agree. Okay. Dr. Rohit, you proceed.
Anyway, only one question. If at all you find a patient where the SPC has been done just above the pubic symphysis, what you will do?
So then I will restage it again, sir, and then plan my surgery. I will redo the SPC at a higher site, sir. Okay.
Now the patient has come to you after 6 months. What are the things that you will ask in the history? You know it is a case of PFUDD because a bladder full is there. SPC has been cited. A young male has come. So what are the things that you will ask him?
So the first thing I will ask about his orthopedic deformity, what kind of, whether he is able to squat or not. Second thing, the most important, I will ask about his erectile function, sir. what was his erectile function before the trauma, and now what is the erectile function now.
Only two things. Will you ask whether he is able to pass urine or drop?
Yes, sir.
What is the significance?
If at all he is able to pass some urine, it means there is at least some continuity in the proximal and the distal ends.
If say the patient is giving a history of erectile dysfunction, so what are the investigations you will ask for?
So your voice is not that audible, sir.
Not required.
Hello.
Hello. Am I audible?
The volume is low, perhaps, sir.
Am I audible?
Yes, sir. Now it's okay, sir.
Oh, I have to, because you have to speak in a loud voice. So what are the investigations you will ask for?
The first investigations for I will go for RGU and MCU, sir.
I am asking very clear that if the patient is having a history of erectile dysfunction pertaining to erectile dysfunction.
Okay, sir. For that, I will ask for a color Doppler study of the.
And what you will see in color Doppler?
Sir, I will see the penile blood flow.
See, in exam, it is not penile blood flow. You have to name the artery.
Name of the artery, the cavernosal artery, sir.
And why not dorsal penile artery?
Also, dorsal penile and cavernosal artery.
Have you yourself done a color Doppler, or you have assisted a color Doppler? A radiologist doing a color Doppler?
No, sir.
That is the thing. It is not easy to see a dorsal penile artery. It is easy to see a cavernosal artery. So, if you want to see the dorsal penile artery, what are the measures you will take?
Pardon, sir?
If you are not able to see the dorsal penile artery, how can you see it? Am I audible?
Sir, volume is low, sir.
Am I audible now?
Yes, sir, little bit. Sir.
How you do a color Doppler? The dorsal penile artery is not seen. What help you can offer to your radiologist?
Sir, we can give intracavernosal injections.
Intracavernosal, what? Not this is very specific. What intracavernosal? Anything? Adrenaline you will give?
No, sir.
No?
Sir,
anyway, it is saprophyrin. So, okay, anyway, now.
Dimix or trimix.
So, on examination, everything is unremarkable. What you will see in examination in such patients? Am I audible or I am not audible?
Audible, sir, but voice is a bit weak, sir. That's why. On examination, we'll see. I will do a DRE and feel the prostate, whether it is the high-lying prostate or not.
Straight away, you will see the prostate.
No, sir. I will start with doing the abdomen, seeing the SPC side. Then I will see the meatus, and then I will feel the urethra. Then I will do the DRE and feel the prostate, sir.
So whether the SPC is correctly placed or not.
Yes,
any
sir.
is there or not. Any scars or sinuses is there or not.
Yes.
You should palpate the urethra and then you do a distal rectal exam.
Yeah.
Dr. Deepu, just things. In exam, make it very clear what are the things you should see in a patient of PFUDD. First thing is the gait of the patient. Second is whether the patient can squat, because if the patient can squat, you are sure the patient can be placed in good lithotomy position. That is the two things you should see. Yes. Third, you see the site of SPC, because that will be important when you go for repair. Yes. Fourth, look for the meatus, look for any scar, sinus, or fistula in the perineum. You feel the temperature of the glands and you feel the sensation of the glands, because this is very important. A patient who has a vascular injury will probably have a cold and clammy glands, versus a patient who has a neurologic injury will have a numb glands. So this is a very important. Without doing a by taking a history of post-trauma importance, and you find the patient is having a cold, clammy, or numb glands, you have to suspect the patient is having a nervous or vascular injury. So never in exam fail to say, I will palpate and feel the temperature of the glands. Okay, next comes the TF. These are must in exam.
Okay. Can I ask the next question? In a distal rectal examination, what is the significance of high riding prostate?
So high riding,
yes.
sir, high riding prostate will possibly guide us that the defect may be long segment defect, maybe there.
Can you rectify, please? In acute, high riding is in acute situation. So what is your inference?
Are you audible
or? Dr. Rohit, your voice is very weak. Some problem with your sound system, audio system.
Please increase the sound.
Okay, I will ask the question in chat box.
Yeah, I'll ask the questions instead of you put it in the chat box. Dr. Tipu, Dr. Bhakti was saying in acute condition, you do DRE in the emergency and you think the prostate is high reading. What is your inference in a high reading prostate in acute emergency, acute cases? Why the prostate is high reading?
Sir, there is a disruption of the pure prostatic ligament. That's why the prostate is high readings.
Anything else?
And disruption of the membranous urethra.
No, you are not right.
What happens because of the ligament injury and there is a lot of blood
hematoma
in the
formation.
pelvic cavity? Yes, hematoma pushes the prostate up. So does it have any significance if you're not planning for any emergency rail loading or end-to-end intervention?
Yes, sir. That will lead to dislodgement of hematoma and lead to massive bleeding.
You did not get my question. Okay, forget it. Next one. This is the patient. The SPC in situ in proper position. Abdominal examination is unremarkable. You find no scars or fistula in the perineum. Meatus is normal, but the patient presents with erectile dysfunction post-traumatic. And in examination, you find a cold, glans penis. Next one.
Sir, then for knowing the urethral defect, I will like to do an RGU and MCU of the patients.
Dr. Rohit, can you show the RGU MCU?
Yes, sir. Dr. Deepu?
Yes, sir. Sir, on the RGU shows the anterior urethra is smooth, well dilated, but there is abrupt cut off at the bulbar end. And the MCU shows the normal contour of the bladder. The bladder neck is opening, and there bladder neck is widely open, and there is cut off at the prostatic urethra. Sorry, yes, the posterior urethra.
What is the standard way in which a RGU MCU is done?
Sir, first we place the patient in a supine position and take a scout film, the KUV film, and including both the hips.
A static film or a dynamic film? Combined
Sir,
film or isolated film?
Sir, RGU is a dynamic film, sir.
Only RGU dynamic. Combined dynamic RGU and MCU is done in the case of a PFUDD.
So,
am I audible?
Your voice is weak. Okay.
What is the name of this investigation? Actually, when the MCU and RGU both coming together.
Yes, sir.
What is the name of this? Name of this investigation.
Downogram, sir.
Yes, a downogram and apogram both are in the
Yes,
same
sir.
film.
Yes, sir.
What is this? It is approximating urethrogram.
Approximating urethral.
Okay. Dr. Deepu, tell me, you are the resident who is placed for this RGU MCU. And how do you prepare the patient? First thing, what are the investigations you should check before proceeding for RGU? What are the things you should have? And how do you place the patient? What is the exact the place patient?
So
Any
first
other yes, tell me.
we'll first proceed with a urine analysis and a urine culture, sir. And then for if the culture is sterile, I will proceed with the RGU and MCU. For first, we'll place the patient supine and take a scout film in a supine.
No, what contrast material? What is the dilution? What is the size of the syringe?
Sir, we'll take a 20 ml syringe, sir.
Okay,
And
contrast.
a contrast will be urographene, 60% urographene, and 20 ml of urographene with 1:1 solution, sir.
Fine. Then position.
The position after taking the scout film, I will turn the patient to oblique 45 degree. The lower limb will be flexed with respect to table in the 90 degree, and the upper limb will be kept straight. Then using a 20 ml syringe filled with the contrast, using a clamp and fix it using a phenyl clamp, and putting the stretch on the penis, I will gently push the saline, and then I will take the RGU film.
Why you inject saline?
Sir?
Why you inject saline?
Contrast, sir.
Contrast or saline mixed with contrast?
Saline mixed with contrast in 1:1 solutions.
Okay.
So how do you be sure that the position of the patient is okay?
Sir, both the obturator foramen should be in the same line, sir.
Both the obturator foramens. Are you sure?
Or there should be no any overlapping bony shadows.
My question is very clear. How do you know the position of the patient is okay? Obturator fossa is fine, but what you should see?
Urethra should be parallel
without injecting the contrast. Sir is asking how you know that the position is all right.
Before injecting contrast.
By saying pelvis, anything you can see on bottom pelvis. Obturator fossa was the first thing that you told, correct. Second thing, I think you missed it. You can see this in an X-ray, the RGU MCU that is in front of. Both the obturator fossas are not visible. One of them is visible, others can be partially. And only it is in an oblique. Am I correct, sir?
Yes, yes. You should see only one obturator fossa, and other obturator foramen you should not see. That is a perfect position. Okay. Okay, proceed. So can you comment on this? This is a doublogram or approximatogram. Okay, comment.
Okay, sir. On
okay, before that, 1 minute. So you are doing RGU. Okay. What is in your mind? Is it a dynamic RGU? Is a static RGU, and why?
Why dynamic and combined film is preferred over static?
So, sir, it's a dynamic RGU because I am pushing the contrast in while taking the film. So that's why it's a dynamic RGU.
Okay. Why you need a dynamic RGU? What is your apprehension?
So that we can see whether the dye is freely going inside or inside the bladder, or the continuity is maintained or not.
Okay. Anything else? What is your apprehension?
Apprehension is if there is extravasation after some time, the film will be not that clear. That's why we are taking the dynamic.
Your fear is you want to see whether there is an extravasation or intravasation.
Yes.
Okay, that is the main apprehension. Okay, and while doing MCU, what are the steps? What are the films in MCU?
So first is full bladder film. Then the next is the voiding film, and the third is the post-void film.
What is the importance of full bladder film?
So on full bladder film, we see the contour of the bladder, whether there is some extravasation or sorry, a reflux or not. The bladder status of the bladder neck.
Two questions on this. You said you want to see the reflux. Is reflux important in a patient who is on SPC for a long time?
No.
No.
Do you see reflux in a patient with SPC?
No, sir. Sometimes.
No.
Reflux
Most
can
of the
be.
time you may see if it is for the long time.
Yes. Patient is
Why?
on SPC. Many times you'll see reflux. Why?
What is the reason? If you don't know, they just say no. Otherwise,
Reflux should not be thing.
Okay.
we generally see a reflux because of the local infection.
Yes.
There is relaxation of the ureteric orifice, gram-negative bacteria. Then you can see a reflux. That is the reason.
Okay. So reflux is not important. You told about the bladder neck. What is the
Sir,
Yes.
could not hear the answer, sir, what Rohit sir said.
patient who is on long-term SPC?
Yes.
Minimal reflux, grade 1 reflux is very common because of the recurrent infection and inflammation. There is loss of this anti-reflux mechanism. So if you find a grade 1 reflux in a patient who is on SPC for a long time, don't get bothered. Okay, but this is different in a patient who has anti-urethral stricture, long-standing stricture, patient has a chronic retention, he has reflux. That is a different issue. But that is not in the case of PFUI because the patient, since the injury, the patient is on SPC. There should not be any back pressure changes. This reflux is insignificant and this is very common. You can see reflux. Okay. So he was telling something about the bladder neck.
Yes,
So
sir.
how do you comment on bladder neck in a full bladder?
Sir, the bladder neck, either it can be a oval shaped or it can be beaked or funnel shaped, sir.
Okay. Anything else?
So that will predict us if it is oval shaped, funnel or beak shaped, there are chances of incontinence post repair.
No, no,
You
see.
want to say that if you
Suppose it is closed one. How will you know?
Closed one, sir, either it can be because of the patient apprehension or
See, there are two situations. You take a full bladder film. One situation is you cannot see the prostatic urethra, bladder neck is closed. Second situation is in full bladder film, you are seeing the contrast in the prostatic urethra, in which case you are happy. Normally, what happens in full bladder?
the bladder, full bladder, the bladder neck is closed, sir. We don't see any
So
contrast.
if you see contrast in prostatic urethra in full bladder neck, you should not be happy.
Yes.
Okay, you think this patient might be having a bladder neck injury leading to a partial closure of the bladder neck. There is cicatrization or scarring, or yeah. So closed bladder, the bladder neck should be closed in full bladder. That is the only importance of full bladder film. Okay, you don't expect any fistula or you don't expect any extravasation of the bladder in a patient who is 3 months old. Okay, but you will have the deformity if the patient had a bladder neck injury at that time. Okay, next is MCU. What you see in MCU?
So we see the bladder neck opening and the length of the posterior urethra and the
you don't see the length of the procedure, see the gap.
gap. Yes, sir. We see the gap of the between the two ends.
What is the significance of that gap?
So whether it can easily approximate the two ends or
The If it is less than 3 centimeter, if it is more than 4 centimeter, 5 centimeter. Is there any data suggesting that if it is less than 3 centimeter, if it is more than 3 centimeter? Why you see the gap? What is the purpose behind seeing the gap?
We see the gap.
The idea, yes. We want to know whether we can bring the both ends together or not. And there is a
Yes.
paper from Curative which says that if the gap is more than the 3 centimeter, there is more than 70% chance that you will require an inferior. So that is the reason why you see the gap.
Yes.
So, Dr.
Yeah.
Deepu,
Yes.
you should look at two things. One is, as Dr. Rohit said, that what is the gap, because that will dictate the amount of mobilization you need to do. And second is what is the lowest level of the proximal end. Suppose a patient has the lower end of the stricture at the inferior border of the bone, or versus the patient who has the lower border high up. Okay, the more higher the lower border is, the more difficult it's going to be. Okay, so now can you comment on this, your take on this patient? How difficult it is going to be, or easy?
Sir, since the proximal distal end of the proximal part is coming up to the inferior pubic ramus, I think it will be easier to mobilize and approximate the gap, sir.
Will it not be difficult case? It will be easy case or it will be difficult case?
Sir, it will be easy, sir, in this case.
Easy. So what next test you will do to confirm that both ends you can assess? What next test you will do?
Sir, MRI gapometry can
No,
be.
MRI is not absolutely indicated. Very small test you can do in your OT, by which you can know.
Retrograde cystoscopy, sir.
Before cystoscopy is always on table cystoscopy. Okay.
Yes.
So what test you will do? Yeah, on that ground, you know that the operation will be very difficult, very easy. Bougie test. Okay, supravegally introduce one bougie and try to fill in the perineum. If you can fill the very easily, that means it can be done nicely. If the bougie is not filled, it is somewhere in the bones or somewhere, it will be very difficult surgery then, isn't it?
Yes.
So suppose you are the surgeon in this patient, your consultant tells, okay, Dr. Deepu, you are third year, you start the case. I'll be coming maybe after half an hour. So what are the steps?
First, before proceeding with the surgery, I will like to take the orthopedic clearance, whether he will be able to squat or not, or putting in a.
Have examined, he can squat very good.
Okay, sir.
You have made a good lithotomy position.
Okay, sir. Then after anesthesia, putting the patient in the exaggerated lithotomy position, and after cleaning and draping, I will proceed with the midline perineal incision.
No, before incision, what will you do before incision?
Sir, actually,
before making incision.
I just want to intervene. We will be discussing the surgery after some time. There is a separate plot for surgery. So should we be discussing surgery at that time?
Okay. No. Rohit, doctor, you proceed. You have other slides also, no?
Sir, before doing surgery, I will do a retrograde cystoscopy or retrograde boogie to see the length of the posterior urethra, sir, whether I can palpate it or not in the perineum.
See, you never see the length of the posterior. What sir said that you first is you can feel for the boogie on the perineum first. Second, people have done boogogram, that is, they have inserted a dilator from the penile urethra and from the bladder, and they have assessed the gap. On NCO also, you get, like in a dynamic film, you can put a scale and gap. Like in this case, it is around 2 centimeters. So these are the ways by which you can assess the gap between the proximal and the distal. See, now last question, 2 questions are, what is Margagnis fracture? These are all Viva questions.
Yes, sir. Malgaigney's structure is a vertical fracture, sir. Ipsilateral sacroiliac joint with ipsilateral pubic superior and inferior pubic ramus.
All the 4 pubic rami are disrupted in
Yes.
Malgaigney. It is a typical butterfly shaped fracture. How do you define straddle injury?
Straddle injury is a fall astride over the perineum.
Okay. And now suppose this MCU, the inferior border of the bladder is say 2 centimeters above the pubic symphysis. So what it means? And any precautions you will take or any advice you will give? Like in this case, the bladder is touching the superior pubic ramus. But suppose you will see MCUs in which this is 2 centimeters above. So what exactly you interpret and what advice you will give?
2 things might be there.
It may be a case where the disruption is there, a high riding prostate is there, and in such cases you allow time for hematoma fibrosis to settle down. These are the cases where you can postpone it for 9 months, 6 months, where you allow the hematoma to fibrose, and so that your operation becomes a bit easier. Any other questions, sir, Bakshi sir, regarding MCU and RGU? Or should I ask one more question?
Hey, one more thing I would like to highlight in combined is other than this gap and the lower end of the proximal urethra, one thing you should see also, is there any change in alignment of the urethra? Sometimes what happens because of the lateral injury, this proximal urethra may not be in the same line of the distal urethra. So those are difficult things, and you should also look for some callus formation in the bone. These are the 4 things you should see in case of RGU and MCU.
And what is pubic diastasis?
Separation of the pubis, symphysis pubis, without any fracture of the bone is known as pubic diastasis.
Any length? What is significant? What is not significant?
More than 2 centimeters is significant.
2.5.
2.
Okay, sir. So I think we can end the case presentation here. Or any more questions related to the?
Sometimes they're asked about the types of pelvic fracture and what is the relation of different types of pelvic fractures with urogenital injury. The student should know which are the factors which causes more importance, which are the factors which causes more urethral injuries, which are the factors which cause more vascular injuries. So they should know what is the type of injury, mode of injury, and their association with the urogenital injuries. That is important. And the different types of urethral injury in RGU and MCU. That is also not covered.
What is Pinto and Callum classification?
Sir?
Pinto and Callum classification.
Yes, sir. That is the urethral injury classification, sir. The grade 1 is only stretch injury, then partial injury. And
grade 2 is?
Grade 2 is the partial tear, sir. And,
okay.
And grade 3 is disruption.
Grade 4A?
Grade 4A is
any other person can answer? Any other MCH candidate is there?
So you should read this.
You read 4A, 4B, and 5.
Okay. Okay, Dr. Ravi, proceed.
So I think we should now move to the next case.
Okay.
I think we are already overshooted our time.
Okay.
So next case.
Can will I show the next case or?
I think Dr. Maji, Professor Maji is there to show a failed PFUDD case. Dr. Maji, can I start?
Failed one is there. I have got a video actually, but video quality may not be so good. Just few days back I did.
Video we'll discuss later. Just finish the presentation first. That will be needed in exam.
Okay.
Dr. Maji, please.
Am I audible?
Yes, you're audible.
What is the history presentation is there? This 40 years male patient.
Can you share your screen, Dr. Maji? Share your screen.
You can share with me for presentation.
Yes, you share your screen.
For presentation, anybody can share.
Failed urethroplasty after PFUDD.
Well, urethroplasty. Devanshu?
Yes.
Devanshu, what are the slides for present slide?
You have the
anyway,
slides with you, no?
I think we have discussed PFUDD. I don't think the slides are there for failed PFUDD.
Okay,
So
okay. What I will do is,
Bachi's-
Dr. Upadhyay, just one
can-
thing.
I have second case for a failed BMJ urethroplasty, or if Bachi sir has any case. I was allotted a failed BMJ urethroplasty, so my second case is ready. If you are willing, then I can.
Okay, you can proceed, but it has to be very short. Okay.
No, I have just done it for examination purpose.
Okay, okay, proceed.
Devanshu sir, I had a question, sir, if I am allowed to ask in between.
Okay. Is my screen visible?
Just Dr. Upadhyay, one of the students has a question.
Sir,
Okay,
like in the case just discussed earlier, sir, there was a injury suggestive of pelvic fracture, urethral injury, but there was no pelvic fracture seen in this patient. So, yes. Sir, should we call this case a PFUI, sir, or does it?
Actually, I think the picture was not very clear and small one. Yeah. If you enlarge it, there are some fractures. That is the issue. There are some fractures. Okay, but sometimes what happens in children, you may not be finding any fracture as such, but these patients will have urethral distraction defects. That happens in children. So you have to take a proper history and look very carefully. There should be some fractures. Okay.
Okay. Occasionally you see no fractures. Okay, so should I start? Who is the student here? Can we allot?
Okay, Shumantra, you can volunteer.
Okay, sir. Okay, sir.
Sumanto has already presented. I think there are many others. Sachin Patel, Kishle, Jagmohan Mishra. Anybody is there who can volunteer? Amit Ranjan, Tapan Kumar Mondal.
Are they visible? I cannot see them.
Manoj, no, I can see the participant list. Nawaz Ali is there. Means any new student. Sumanto has done. Dipu.
Yeah, Dr. Siddharth is there, I think. Dr. Siddharth from Guwahati. You want to participate?
Yeah, anybody should be participating. Siddharth, are you there?
Dr. Siddharth or Dr. Sachin, you are third year. Are you here?
So anyway, so who is willing?
Dr. Ram Kumar, Dr. Ram Kumar, your name is here in the students.
Hello.
There are 4 names given to us: Dr.
Hello?
Deepu, Dr. Kasim, Dr. Shumantra, Dr. Ram Kumar. Yeah, Dr. Ram Kumar.
Yeah, Ram. Hello.
Ram Kumar.
Am I audible, sir?
You are audible, but your video is not there. Yeah. So we'll start with this history that a 40-year-old male has come with no okay. 45-year-old male, and there is a history of poor flow for last 2 years.
Oh.
And he is telling that the frequency in daytime was 6 and night is 3 times. And he is having severe straining with sense of incomplete void. So this is the history. So any other thing you would like to ask? 45 male, and these are the histories.
Yes, sir. I will ask about any associated with urgency or dribbling of urine
Okay, no urgency, no dribbling.
and other alerts.
Okay, this is important thing. It is poor flow frequency. You should always start whether there is any hematuria or any symptom suggestive of UTI. Anyway,
Right.
says there is no medical comorbidity, and the history of buccal mucosal graft urethroplasty was done 3 years back for post-cateterization bulbar urethral stricture. Patient was all right for 3 months and then developed progressive decrease in stream, for which DIU was done twice at a gap of 6 months. So this is the history. So anything more in history you would like to know?
Sir, I want to what type of surgery has been done at that time, and in
Dorsal
post-op.
BNJ. Dorsal
Okay.
BNJ.
In sir,
Araglide.
post-op period, any complication was there or not?
No, no
Any,
complication.
like hematoma formation or
no,
urinary tract
no
infection.
No complication. So anyway, we will go to the question answer. We will again see later. Now examination, everything is normal. DRE is normal, and investigations are also normal. Hemoglobin is 11, counts are 4800, platelet is normal, fasting sugars are normal, liver function test is normal, urine examination is normal except leukocyturiuria is there. Ultrasounds are also normal except that the bladder wall is 8 mm thickened with a PVR of 120 mm. And this is the Uroflow, which is obstructive, and this is the RGOMC. So the complete history is now there with you. So the question that I will ask: do you think there is any role of DVI following PMGU failure? If you have done a dorsal buccal mucosal graft urethroplasty, do you think after a failure there is a role of a DVI?
Sir, if the structure size is small, then we can go for the DIU.
How many times?
Structure size less than 1.5 centimeter.
No. My question is very clear. Post dorsal BMJ urethroplasty, there is a recurrence. Is there any role of a DVIU? How many times you can do? What is the criteria of the stricture which fits in that you can go for a DVI?
If sir, a small segment structure is there less than 1.5 centimeter, so we can do DIU.
Ramkumar, I want to ask you one question. And which site of the stricture you will do DIU? Penile urethral stricture, bulbar urethral stricture. Where you want to DIU?
In sir, bulbar urethral stricture.
In penile urethral stricture, do you do DIU? Is it indicated?
We can do, sir.
No, you cannot
What
do.
is the classical indication of DVIU? That is what sir is asking. In one line, you tell what is the classical. My question was different. But Bakshi sir is asking you what is the classical indication of a DVIU in any
where
case,
DIU is indicated?
in any case of stricture.
Sir,
What is the classical one line?
Sir, it is only indicated in if after post prostatectomy, if there is.
No, this is not correct. Any stricture, Dr. Rohit is asking you in which condition you will do DIU.
What is the indication?
Number one, single stricture, less than 1.5 centimeter, and soft strictures. Triple S, single, soft, and short. That is the 3S is the indication, and the stricture located in the bulbar urethra. Okay.
Okay.
Stricture to be located. Now, it's coming to my question. In a post dorsal BMJ urethroplasty failure, what is the role of DVIU? Anyway, I think we have asked this question. Generally, if the recurrence is at the anastomotic site and the lumen is more than 10 French, then you can attempt a DVI once. One DVI you can do, not more than that.
Okay.
Second question regarding DVI will ask, is there any difference if the patient has a recurrence after 3 months or after 2 years? Anybody can answer this question, not Ram Kumar. Devanshu, Deepu, is Deepu there?
Yes, sir.
Anybody can answer this question. Is there any difference in the results of DVI if the recurrence is after 3 months or after 2 years?
Sir, probably a later development of recurrence after 2 years is due to progression of the disease process. So this involves development of spongiofibrosis. So DVIU is possibly not useful in this scenario. However, in the early stages, it's a flimsy adhesive or flimsy layer of stricture that can be resected by.
What is in your mind? I'm not asking about a post-urethroplasty failure. I'm asking after a DVIU, you have done a DVI, not regarding this. You have done a DVIU for a focal bulbar urethral stricture, and there is recurrence after 3 months, and in second case there is recurrence after 2 years. What is the difference? What exactly is going in your mind?
The early recurrence. The early recurrence means it's a more aggressive kind of disease, so it will not be helpful if you do a DVIU.
Sir, early recurrence is probably a technical error.
So DVIU may technical. I mean to say aggressive is suggestive of aggressive disease, sir. If it's early recurrence.
Suppose the spongiofibrosis is very dense.
Yes.
Okay. If the spongiofibrosis is very dense, very hard, so DVIU, will it be successful or it will be failed DVIU?
Failed DVIU.
Huh?
Failed. If it is dense spongiofibrosis, it will be a failed DVIU, sir.
Yes.
Actually, the thing is that you should not do more than a 2 DVIU. If the recurrence is within 2 years, the chances of failure after second DVIU is almost 100%. But if it comes after 2 years, still you will have 20 to 30% chance of success in a DVIU. So that is the thing for doing. How many times you should do a DVIU?
Maximum 2 times. Yes, third DVIU is not advised, sir.
Not advised.
Okay, Dr. Deepu,
sir.
Suppose if I tell you, Deepu, do DVIU in these patients, and after you have done the DVIU, I ask you what was the findings and what do you think this patient is going to do in future? Is it a bad stricture? Is it a good stricture? So how do you explain to me this answer? I'm your consultant. You are the third year resident.
Sir, if
you have done the DVIU, report me.
Yes, sir. If it was a short stricture or it was a soft stricture, as sir said, sir, and my scope could easily negotiate into the bladder after the procedure, and there are punctate bleedings from the side. It is a successful DVIU, sir.
What are the things you have noticed? One is
passage
punctate bleeding. Okay. Second is
easily passage of the scope into the bladders.
What does that mean?
Sir, it means that
while cutting, what do you see while cutting? You are cutting the stricture.
Yes.
What do you see?
Sir, we should see up to the punctate bleeding, sir.
Okay, that is your limit. But what do you see? You see, it is a spongiofibrosis or it's a mucosal stricture. Suppose a patient has only mucosal stricture, you cut it and the urethra opens up. That is a patient versus a patient. You go on cutting and everything you cut is a spongiofibrosis, and you see the distensibility of the urethra after cutting. It's not that how easily you can go. You see the distensibility. You keep your scope just distal to the stricture and try to distend the urethra. Some patients will find the urethra is nicely distending, and you know this patient is having minimum amount of spongiofibrosis versus a patient who has a good spongiofibrosis. You may not be able to do a good distensibility. So you should see bleeding, you should see distensibility, you should see spongiofibrosis, you should see what is the length and what are the numbers of strictures. Depending on this, you should categorize this patient as a bad stricture or a good stricture. Okay, this is the 5 things you should see. Okay. Anything else, Dr. Upadhyay, you want to ask on DVI?
What is the size of the urethrotomb? Your Deepu?
Sir, 21 French, sir.
And what are the various shapes of knife you use? You know of? Enumerate.
Sir, one is straight, one is half moon, one is half moon, and another is
Sickle shaped.
sickle shaped, yes, sir, sickle shaped.
How many you have seen? Only the straight one. What is the name of that instrument that you use?
Success urethrotomb.
What are the other sizes of urethrotomb you know of? Only 21 French or other sizes are also?
So I have not seen much.
Pediatric urethrotomb?
Yes, the pediatric definitely.
And suppose you are doing a say a 10-year-old child and you have only a 21 French urethrotomb. So, and there is a stricture. So how will you manage it? A 10 or 12-year-old child comes, say a very focused stricture is there. On a ureteroscope, you see that a very focused stricture is there, but you have a 21 French ureteroscope. So how will you manage it?
So if I have a ureteroscope, I can use a ureteroscope and a Bugby.
Bugby for a stricture.
Or a laser if I have a laser, then.
You can use a laser or you can do a coaxial urethral dilatation.
Yes, coaxial.
Have you done a coaxial urethral dilatation?
Yes, sir.
What is how you do it?
Sir, first we under the visualization we pass a guide wire first.
And then how you dilate it?
Then we sequentially dilate either using PCNL facial dilators or ureteric dilators.
Okay. And now tell me, what are the complications of DVI?
So complications are immediate complications like bleeding and hematoma, swelling of the penile hematoma, and post-operatively it can lead to erectile dysfunction.
DVI leading to erectile dysfunction.
Sir, if there is a
how common it is?
Very rare, but possibilities there. If there is
rare things, you should not be speaking rare things.
There is chance of prolonged erection.
Yes, you encounter a brisk bleeding. What you will do? What are the steps you have seen that your consultant has done?
Sir, we'll put a catheter and put a perineal pressure.
Through by perineal pressure by what?
By putting a figure of X and come Dynaplast.
Compression dressing is
there. Yes, sir.
Have you ever used Bugby or a current to cauterize the bleeding? Have you ever seen? Just asking.
No, sir.
Good. Any other questions, sir? Bakshi sir?
How long will you keep the catheter after DVI?
Sir, we generally keep up to 3 to 5 days, sir.
Yes.
And any postoperative advice to the patient to maintain the patency?
The first few weeks, we ask the patient to do a daily self-calibration.
Calibration.
Dilatation, sir.
Is it? After doing OIU, you ask the patient to do dilatation.
Daily
do you do routinely this? And what is the terminology called failure after DVIU?
Failure of the DVI, when slowly the patient has a decreased flow in the urine. It's called failure in the DVIUs.
How to document this failure or not?
So only by uroflowmetry, sir.
Do you do anything after DVI or you just let the patient to go home? Anything else? You do not dilate the patient. What do? You can do.
Sir, ask the patient to do CIC, self catheter.
No, it's not CIC.
It is not CIC.
What is this called?
Calibration.
Sir,
yes, self-calibration.
Self-calibration.
Right.
Why is it called calibration?
Sir?
Why it is called calibration, not dilatation or CIC?
Sir, in calibration means just to maintain the patency, whereas dilatation we sequentially break the
no. Never break. In dilatation, never break. What is the meaning of urethral dilatation? When we use metallic dilator or other elastic dilator, what is the meaning of urethral dilatation? We just basic principle.
Increasing the lumen size or
No. What is that? What is dilatation? Urethral dilatation.
You have to stretch the
You
scar.
You stretch. You never break. Once you break, again there will be fibrosis. More severe stricture will be there. Okay. So calibration means you maintain the caliber of the urethra. Okay.
Yes.
Now coming to this case, a dorsal BMG urethroplasty was done 3 years back, and you can now see that again there is a whole segment recurrence of the bulbar urethra. So Ram, what are the options you will tell to the patient?
Sir, so it is a long segment stricture, so we have only one option like open surgery, and mostly we prefer for
What are the options? What options? Recon surgery the patient will undergo, but what are the options that the patient has? 1, 2, 3, 4. First option, second option, third option, fourth option.
Sir, whole segment BMG urethroplasty or
whole segment dorsal BMG.
No. Whether you want to do a stage surgery or single stage surgery. First of all, you tell me.
Yes.
This is a long segment urethral stricture and recurrent urethral stricture. You will have to give a test result to this patient. Huh?
Stage surgery, sir.
Already once BMG urethroplasty has been done in this patient, twice DVA has been done in this patient, and now the patient has come to you. You will have to give some concrete treatment to this patient so that patient becomes happy with your treatment. What surgery you will do?
Sir, if the patient in the retention or any other problem, then we first do SPC, and after that we plan for the surgery in the second stage.
Okay, SPC. If the patient is not in retention, okay, anyway, you do a SPC. My simple question is, what are the theoretical options? What you will do is, okay, but what are the options? I just want to know how much you have read about. That is the intent of the question. What all options are available in this case? Failed BMG.
Sir, failed BMG, either we can go for the single stage or double stage. In single stage, we can
you should
go
not
for
say double stage. You should say stage procedure or a single stage.
Stage procedure.
Stage or a single stage. Now, what are
Sir, in stage procedure, we have a Johansson's lay open in the first stage. After that, the retubularization.
Yeah. Okay, first come to the single stage operation. What are the options in single stage? Thirdly, just I'm asking what you know of, how much you have prepared in your.
Just now we discussed all these things. Just now we discussed.
In first stage, we have the either dorsal flap, dorsal trapezial flap,
or graft.
Flap, sir.
Flap, okay.
Dorsal trapezial flap.
Sir, orandy longitudinal flap.
Ventral or dorsal? See, you should be.
Sir, in ventral flap, we have options like orandy flap, sir.
Will you be able to do orandy flap in a bulbar urethral stricture, which is almost going right up to the proximal bulb? See, here options are ventral prepucial flap, or you can do a ventral onlay flap, onlay buccal mucosal graft in a single stage setting. And the rightly said, the second option is a stage procedure where you will open up Johansson stage 1, followed by the closure with or without buccal mucosal graft. Am I right, sir? Bakshi, sir.
Yes.
Any other option?
Perineal urethrostomy can be considered. A permanent perineal urethrostomy can be considered.
Yes, very good, very good. It is also a very good option. Perineal urethrostomy can be done.
Sir, if you give me this case, I will definitely do stage surgery. I will first stage, I will do Johansson's urethroplasty, and second stage, I will close with a dorsal inlay, BMG graft, and closure. Because already the patient has failed.
Actually, this is a case, so I just wanted to check whether they know all the options.
Yeah. Okay. Anything else, Dr. Upadhyay, on this case?
No, I don't have anything from my side.
Okay, so I'll be sharing a patient just to add on to your last case on PFUI, a failed PFUI.
First, I will stop sharing.
Yeah.
Okay.
So this is Dr. Upadhyay has done a wonderful job on the last case, but after 3 months, the patient comes back and this is the UMCU. So who wants to take the case? Anyone from you?
Sir, I can take.
You can take. So
Any new
tell me.
person is not there.
Actually, there are only 4 residents who was
Okay. Yes.
Yeah,
Yes,
yeah.
yes.
So maybe others are not prepared. So they're not volunteering. Okay.
Kasim is there.
Kasim,
Yes,
are you
sir.
there? Yeah.
Yes, sir.
You take this case. This is a patient who failed after end-to-end anastomotic uretroplasty. So it does describe the RGFWgram.
Sir, in doubleogram, film shows the sir. They, there is the uh, gap is seen from the whole bulbar region. So
Whole bulbar
from
region. Is specific.
uh,
You have seen the previous RGU-MCU in previous cases by Dr. Upadhyay. Do you find any difference between these two doubleograms? And what is the difference? Why? This is a very specific of post PFUDD failure cases. What is the specific thing you can see here? Dr. Shumantra, can you answer?
Sir, this patient, the proximal part of the bladder and the proximal urethra is shown in this image, and the RGU portion shows dilated urethra, but there is a segmental loss of urethral tissue
Yes,
on this.
that is the most important thing. What happens in PFUI primary cases? This is a distraction defect. Actually, there is no loss of urethra. Okay, it's only a distraction. So you can see the whole C of the bulbar urethra. There may be 2 centimeter, 4 centimeter, 5 centimeter gap, but still you can find the C loop of the bulbar urethra. What is not here? So this is very classical of urethral loss or urethral necrosis. In primary cases, you will see a gap here, but you can see the C loop of there, which is not here. So this is a clear-cut case of urethral necrosis, which is seen in post of failed PFUA surgeries. Okay, so you have a gap. So why do you think this patient had a urethral necrosis? What went wrong? What do you think?
Dr. Devanshu, you use the word proximal urethra. What is proximal urethra?
No, sir, I'm
No,
sorry,
this is a
Dr.
bulbar
Upadhyay,
urethral
this is a
necrosis.
bulbar urethral loss. Bulbar urethral. Proximal is absolutely fine. So what went wrong in this case? Why this patient had a bulbar urethral necrosis?
sir,
The primary pathology after the trauma was associated with a vascular injury, and it was undetected or unsuspected in the preoperative period.
So
So
it was suspected because this patient had importance post-operatively. That was one clue. Then what went wrong?
Which artery is damaged? Sir is asking which artery is damaged.
Sir, in this case, the urethra has a dual modality of blood supply from the proximal as well as distal. So, in process of the surgery itself, the bulbourethral arteries are resected. So, if the patient has an already injured during the trauma, if the cavernosal arteries are injured, not cavernosal, sir.
The dorsal penile artery.
The dorsal penile artery, if it is injured from the previous trauma, then the distal part of the urethra blood supply becomes risky, and so after this procedure, there is necrosis or loss of the urethral segment after anastomosis.
What precautions you could have taken during the primary surgery?
Sir, if I had suspected such a scenario of vascular injury in the primary scenario, then I would have ordered for a Doppler of the Doppler of the internal pudendal artery system, both the cavernosal, the dorsal penile, and the bulbourethral arteries. And if that suggested a vascular injury, I would perform an arteriogram and followed by revascularization of the penis, depending upon the site of it.
what is the guideline if you find a vascular jeopardy preoperatively? Is it necessary you do arteriogram and revascularization? What is the current status? Is it indicated?
Sir, I am not aware of the exact guidelines, but if there is a vascular injury with presence of clinical signs and symptoms like erectile dysfunction and loss of temperature on the glands, so then an option is penile revascularization surgery. I'm sir not aware of the exact guidelines.
Is an option. See, the amount of blood which is needed for erection is much more the amount of blood which is needed for a successful urethroplasty. So it is not in the guideline that even if you suspect a patient who has a vascular jeopardy, it's not mandatory that you should do a revascularization. In fact, that is not done. Only thing is you have to be very careful during the surgery. You should do minimum dissection distally. Okay, that is the thing, and you should have low threshold for doing inferior pubectomy so that you do not do the surgery under tension. Okay, you should not go for any revascularization. But the question is why you should do a Doppler? It is just to quantify the risk of anastomotic failure so that you can tell the patient, yes, you have a vascular jeopardy. It's not mandatory that you will have to do a revascularization. Dr. Bakchi, your take on this point regarding revascularization?
Yeah, revascularization is not definitely helpful in these situations.
Okay. So
already
why
chronic changes has taken place.
Yes. Why I showed this is you should not forget this kind of picture where you have a clear-cut necrosis of the bulbar urethra. You should not miss this. Somebody, the examiner might ask you, what do you think? This is a primary case or this is a failed case? If you see this kind of pictures, you say that this is probably a failed case because I cannot see the C loop of the bulbar urethra. Okay, so what next? This is the patient. What next? He has a bulbar urethral loss.
Sir,
what are the options you have?
Sir, this patient requires tubularization procedure to make a new urethra.
Okay. Options.
Tubularization means what? What do you mean by tubularization? You make a tube.
Yes, sir.
Sir, we can do, sir, double face BMG. Can we do, sir, in this case?
Double face BMG.
No,
What do you put the BMG here? Anything else? More common you can do, more easy you can do.
The exam, you should give all the options. 1, 2, 3. What are all the options there? First option,
somebody talked about the tubularization. So tubularization means what? You please describe the tubularization.
Sir, we have to create a new urethra to bridge the gap. So,
okay.
So,
from
sir,
which? From where you will bridge the take the new urethra? Where from you will make the new urethra?
Sir, the available options are. Sir, I'm not very confident about the options here, sir. I have not encountered such cases regularly. Sir, I'm very
Pipu, Ram, anybody can answer. Pipu, Ram, Kasim.
What is pedicle graft?
So pedicle can be taken, tubularization can be done by the dartos fascia, sir.
Oh, dartos fascia is not tubularized. Tell me what tubularized, what is you have got tubularized things. If a pedicle flap, where from you will take a pedicle flap?
Sir, scrotum.
Scrotum is a hairy thing. You cannot make. Yes. One from the prepuce, another is. What is mechanic flap?
Mechanic is a transverse flap, sir.
Sir.
Where from it is made?
Sir, it is made from the penile skin, sir. It is taken
from the proximal penile or from the distal penile?
Distal penile, sir. From the distal penile, circumferentially it is taken, and then it is slit on the ventral side to make a longitudinal flap, which can give length. up to 15 centimeter that can be tunneled and brought into the proximal urethra.
That is one. Suppose you are not that expert, because mechanism is a very expert surgery. You have done the initial surgery, so this is your onus to give a good urethra to the patient. What easier things you can do? I will give you a clue. Stage procedure.
That's why all the options you should say, not in exam. All the options.
Have you heard of scrotal drop back?
Sure.
So you can bridge, you can bridge the gap by bringing the scrotum there. One end has to be sutured to the proximal end, other end has to be to this distal end, and after that you have to epilate of the scrotum by using a laser. And in the second stage, it tubular is. This is the easiest solution. The easiest solution, anybody can do this. Second is you can do a perineal ureterostomy by taking a perineal flap. Okay, this is a staged operation. And regarding tubularization, one is Macanich, what you have already told. Second is you can do a Singapore flap. What is that Singapore flap? This is basically a groin flap. Anything else you can do? More complex? You can do a free flap also. Okay, that is also acceptable. These are the 5 options. In exams, you may be getting this kind of questions, and you have to know at least 3, 4 options which are there in this case of bulbourethral necrosis. Okay, I think this is all for this case. Any other case, Dr. Bakchi and Dr. Upadhyay, you want to share?
Can I show one urethrocuteneous fistula?
Yes.
Regarding this case, I will like just one comment. There was a discussion on revascularization.
Yes.
Actually, publication is from Jordan regarding revascularization. It is not in the guidelines. Just for the thing that if it is less than 25 centimeter per second on cavernosal artery, a revascularization can be done between inferior epigastric artery and the deep dorsal artery on both sides, or you can do even with the deep dorsal vein on one side and deep dorsal artery on the other side. But it is not there in the recommendation. But it has been described in one publication from Dr. Jordan.
Okay.
Just for completing the theory part.
Okay.
Okay, and next is, I think the cases are done. Okay, videos you have to show. Dr. Upadhyay, you are telling about the steps of PFUI surgery.
No, I think case with the urethrocuteneous fistula is remaining.
That is discussed in the first case by Dr. Bakchi.
Already we have discussed more or less.
Let's go to the videos.
Okay. So actually video, I don't have a video. I have presented it in a PowerPoint so that the steps can be discussed.
Yes.
Each
yes.
step should be discussed. Okay. So I will present that. I'm taking time. Somebody else can also do if they wish. Okay, so I will present. Let me try again. Is my screen visible to everybody?
Yes.
Banshu sir.
Yes.
Yeah. Is visible.
So again, these things have been discussed, but again, I will go back. Like in history, what you should see is that whether the mode of injury, whether it is a straddle or whether it is being run over or thrown away, because all this describes the severity of the injury and whether the patient was in a complete retention or he is able to pass some urine. Because if he is able to pass some urine, that means that you will have some easier surgery to be taken care of, or any history of laparotomy or a railroading was there, whether any catheter was sited or not. And always be very careful. You should look for any sinuses is there or any fistula is present or not. You should very carefully see the X-ray QB and see whether any bony spicule is going inside the bladder, or what is the level of the what is the severity of the pelvic fracture, or any other external fixators has been used, or any hardware is there. You can see internal fixators on the X-rays. So these are the things that you should carefully look for. You should always ask about the history of erectile dysfunction, because just Sarkar sir told us, because if there is a history of erectile dysfunction, then there are chances that you may land up with bulbar urethral necrosis if you are not very careful. And in children, you should ask the parents to notice whether the child is having morning erections or not, because in pediatric cases, the disruptions are severe and the complications are more. So you should be very careful. And last but not the least, most important is you should inquire about the gait, whether the patient is able to sit and squat, because they will affect the positioning of your surgery. Examination, I told, always rule out any lump, any fistula is there, any osteomyelitic scar where you can see sequestra coming out, or any bony spicule is inside the bladder. These are the things that you must carefully look for. And you can see whether the patient is being able to sit in a squatting position. And always rule out, do a DRE, always see whether it is a high riding prostate or not, or any urethral discharge is coming. You may be surprised that occasionally there may be a rectourethral fistula or any abscess might be there, which can complicate your surgery. So don't dismiss things. You should be always very careful when you are doing an examination. Investigations, I think it has been described. You should see a X-ray QB, how the four horns are there, any fracture is there or not. Rule out any bladder stone, upper tract stones, particularly when you are dealing with poor patients who are an SPC for 2 years, 3 years, 4 years. You will be surprised that big bladder stones are there. So it's always a nice idea to first do the stone, clear the bladder, make the bladder pristine, and then again come after 3 months and do a proper like in this case, you can see a significant pubic diastasis there more than 5 centimeters, where you expect a severe urethral disruption, more complications like incontinence or bulbar necrosis in such cases. You should always be visible, very careful about delineating what is the kind of pelvic fracture, whether any sacroiliac disruption is there or not, because all of these things show how severe the injury is. And the more severe the injury is the more chances that you will have an adverse outcome by doing the surgery. Always take care of the hardware, where the internal fixators are there. And occasionally it is a very good idea that if an internal fixator is there and you think that internal fixators will come in your surgery, then you can consult your orthopedic surgery whether that internal fixators can be removed or not. They are generally able to remove it after 6 or 9 months. And if you think that they are coming in your surgery, it's better to remove it and do your surgery later on. Like in this case, if you go for a transpubic or an inferior pubectomy, it will be very difficult. So always take an orthopedic consult. Make sure that if possible to remove internal fixators after say a period of 9 months, then always remove and then go for surgery. See for the integrity of the bulbar urethra, see the gap that we have described, whether it is 3 centimeter, 4 centimeter, or 5 centimeter. Always see for the gap between the lower border of the cystogram and the pubic symphysis, and rule out any fistula. Though it is very uncommon, but doing a surgery with a fistula is always a disaster. So better to rule out beforehand and plan accordingly how you are going to tackle that fistula. And this is a typical type 1 injury where you can see a stretched, elongated posterior urethra. And this is a typical PFUI that I discussed in the last case. This is what Sarkar sir told. This is a typical case of a bulbar urethral necrosis where the proximal bulb has converted into a ischemic stricture. So these are the things you should always be careful when you are evaluating a redo PFUI. Now, before going into the steps, I will briefly describe the history. In 1962, the peers described the exposure of the posterior urethra by doing a total abdominal pubectomy. In 1973, Penn and Coombs described a direct transpubic excision of the stricture and end-to-end anastomosis by single abdominal incision. In 1973, Waterhouse described a new approach using a perineal-abdominal progressive approach, perineal incision for mobilization of the anterior urethra and abdominal incision for the transpubic anastomosis. Turner Warwick in 1976 described the use of omental wrap to give a support, vascular support to your anastomosis, and the classical progressive perineal urethroplasty that we know of was described by Wester and Gold, and he also described the transpubic wedge excision, which was also described by Pierce. Now the position is basically the most common position is social lithotomy position. In US, generally they give exaggerated lithotomy position with perineal postures. You should make sure that all pressure points are well batted, because in post-op period, if these positions are not well padded, the patient may complain of pain. So this is the typical social lithotomy position that we use, and this is the extended lithotomy position with a perineal posture. The incisions are midline perineal. You can give a midline perineal with a lambda extension. You can give a blandly inverted U incision. And for transpubic, you can give a midline abdominal incision or a midline abdominal incision with an inverted T extension over pubic symphysis for ease of doing abdominal pubic symphysis. So while you are giving a perineal incision, the only thing that you should take care that you should not go very high on the scrotum, because it doesn't give you much advantage. But the only problem with that is that the scrotum hangs down and it creates a problem in your surgery. But having said that, you should never compromise on the incision. If you are not feeling comfortable with the length of the incision, always better to extend the incision. First is the skin and the dartos, and then comes the bulbospongiosus muscle. Like while you are cutting the bulbospongiosus muscle, there is a thin layer of a shiny fascia which is just above the urethra, which is also called as Gallaudet fascia. If you can find the plane between the Gallaudet fascia and the urethra, then generally cutting the bulbospongiosus muscle becomes very easy, because it is generally a very pristine plane where you can go easily without creating lot of bleeding. I would like to see you this slide very carefully. You can see this Gallaudet fascia is there, a nice fascia is there, and you can see the healthy urethra. So if you can find the plane between the Gallaudet fascia and the urethra, then separating the bulbospongiosus muscle becomes very easy. And typically when you are going around the urethra, then cut the Buck's fascia so that you can go around the bulbar urethra very nicely. You should be going around the bulbar urethra. Circumferential mobilization should be there, distally up to the penoscrotal junction. But if you are suspecting that the patient is having a erectile dysfunction, then like Devanshu Sarkar sir rightly told, that you should limit the distal exposure, because that it also hampers the blood supply. This is a typical where you feel that you have mobilized the urethra up to the penoscrotal junction or not, because if you have not done an adequate distal mobilization, then that is one of the causes of the failure. And this is very critical step, how to separate the proximal urethra from the bulb. This is the step where initially you will find lot of bleeding. So it is always better that you pull the urethra up so that you can nicely see the plane on the ventral part and on the sides, and you can do a sharp dissection with scissors without going into the bulb, because if you are not very careful, your scissor may enter the bulb and you will needlessly encounter brisk bleeding there, which maybe have to be controlled with suture ligation. And bulbar urethra has to be circumferentially mobilized right up to the penoscrotal junction, or a bit less if the situation demands so. And this is again a very critical step, that you have to go to the proximal part as much as possible. Here, two things are very important, because there is a muscle surrounding the perineal, but the transverse perineal muscles are surrounding the proximal urethra. So if you are not very careful, then you may land up inside the perineal muscles where the planes are lost and needless bleeding is encountered. So it's always better that you pull the urethra with an infant feeding tube or with an umbilical tape or with a sling, whatever you are feeling comfortable. And on the proximal part, your scissors should rest on the urethra and you should dissect as proximally as possible, because this step is very important. Because if you don't dissect as proximally as possible, then you won't be able to transect the urethra distal to the stricture, and you may unnecessarily cut into a healthy urethra, and you may lose a centimeter of a healthy urethra. So it's always better that you go as proximally as possible, and you lift the urethra from the perineal body and go as proximally as possible. Like you are saying here, Asha, now regarding the extent of the distal fistula, two methods have been described. First is what I use, I put a Nelker catheter and then I feel for the tip. If I can feel for the tip, means my dissection is done. Or you can introduce a small dilator 9 or 10 and you can rotate it laterally to and feel for the tip. If you can feel for the tip, then you have reached the proximal part, the proximal part of your dissection, and you can transect the urethra. Ideally, when you are transecting the urethra, you should not be able to see the Nelker cath coming out of it. That means you have unnecessarily lost millimeter, 2 millimeter, or 3 or 4 millimeter of your healthy urethra. Then after cutting the urethra, the next thing is to minimize the gap between the proximal and distal urethra. So the first thing is to cut the triangular ligament. Second is separation of the corporal corporal bodies, the corpora cavernosa. Third is inferior pubectomy, and third and fourth can be either a transpubic approach, or you can do a rerouting of urethra around the corpora cavernosa. So this is, we have cut the triangular ligament, we have separated the corpora cavernosal body, and now we are in the process of doing a inferior pubectomy. While doing inferior pubectomy, two things are very important. You should separate the corpora cavernosa by at least 2 to 2.5 centimeters. Because if you have not separated the corpora cavernosa 2 to 2.5 centimeters, then generally your anatomy of the pubic symphysis is not very clearly visible. And even if you cut the pubic bone, still you may not find a lot of gap. And when you are working in a clumsy space, there are more chances that you will damage the deep dorsal artery. So it's always better that you separate the corpora cavernosa by at least 2 to 2.5 centimeters. You clearly delineate, you elevate the periosteum, and then you do a good pubectomy. And now, even taking out the inferior wedge of a pubic symphysis, two methods have been described. One is by Dr. Kulkarni, where he says that you have to go and you have to raise the subperiosteal flap, and then you have to do a pubectomy. Other method is that you do a wide corporal separation, delineate the pubic symphysis clearly, and then you do a wide omega shaped pubectomy, so that your posterior urethra is very clearly visible. You can do a very good scar excision, and even taking your sutures is very easy. The important thing when you are dissecting the posterior urethra, that it should be healthy, it should be pink, and it should be pliable. Now, what is pliable urethra? The best test that I use is that when you pass a suture through the posterior urethra and you pull it, you should be able to pull the posterior urethra. If you are not able to pull the posterior urethra, and if it is cutting through that, generally means that your suture is through scar and not through healthy urethra. So you should again go more proximal, take out scar as much as possible from say 3 to 9 o'clock, and again take a suture. Because if you are taking suture from the proximal scarred part, there are more than high likely chances that it is going to fail. So first thing is that you should see a supple urethra with a protruding healthy mucosa, where you take a suture and it doesn't cut through, and you should see the posterior urethra very healthy. Posterior mucosa should be seen from the anterior part. That means now you have reached the proximal urethra, which is very healthy. And this is the technique that I use. I pull it. If there is no cut through and you can feel the pliable urethra where it comes out easily, that means you are in the healthy urethra. And this is a slide of the scar excision. You excise the scars. The scar is typically white, firm scar. You can do it circumferentially or by quadrant method, whichever you feel you have been taught. And this is a slide where you can see the healthy mucosa is being protruded by stay sutures all around. Now, posterior pubectomy, again, two approaches has been described. One is a transpubic approach where you remove the entire pubic symphysis, but that is associated with complications like waddling gait is there, and at times it is associated with very bad hernias, which is very difficult to repair. So Dr. Kulkarni has promoted this method where you preserve the anterior part and you create a cave in the posterior part, and then you do a posterior urethral dissection. This is generally very useful in pediatric cases or in a female PFUI, or in cases where the proximal urethra is high riding just above the pubic symphysis. Thank you.
Thank you. Dr. Upadhyay, can I add some points with your presentation only? This is an excellent presentation.
Only thing I would like to say is that better to ask the student about the various nuances of the steps.
No, just to inform the students only. Things
Yes,
that
yes.
the principles of this operation is number one, excision of all scar tissue. Whichever scar tissue comes in your way to the surgery, you excise all the scar tissue, both proximal and distal end of the urethra. And number two is the anastomosis should be done to the supple urethra, as you told. And third is that it should be a tension-free anastomosis. So there should not be any this tension between the suture. Pulling the thing is not good. So it should be tension-free anastomosis and watertight anastomosis. And another thing is that in a young patient who is sexually active, it is better that we preserve the bulbospongious muscles. We do not divide the bulbospongious muscle. It is for better ejaculation as sexual function. We preserve the bulbospongious muscle. And this is another thing. And another thing is that, as Kulkarni sir taught us, is that the blade of the thing, what is that called? The diathermy monopolar blade should be made 90 degree, and it should leave the periosteum in the midline and to either side, so that we can avoid the injury to the cavernosal vessels. These are the things only I want to add.
Okay, so
nice presentation, and all the steps has been nicely delineated by Dr. Upadhyay.
Any student who would like to come so that we can ask questions regarding the steps and the follow-up? Ram, Kasim, Deepu, anybody? Sumanto?
Hello. Hello.
Yes,
Yes,
Dr.
sir.
Machi.
I think your younger urologists have to tackle another type of new coming stricture, that is vesico-urethral anastomotic stricture, as number of radical prostatectomy increase. As till now there is no guideline. I think in future a guideline will be programmed for this type of stricture. So younger urologists has to learn how to deal with this type of stricture.
So, Dr. Deepu, what are the various arteries that we encounter while doing a PFUI surgery? Deepu,
Sir,
Kasim, yes. Name all the arteries that you cut.
sir, at the bulbourethral junction, we cut the bulbourethral arteries.
There is anything called as bulbourethral artery.
Urethral arteries. Urethral arteries.
Okay, what are the, and before cutting the bulbourethral arteries, what other arteries you cut? Sequences wise, first artery, second artery, third artery. Do you cut the circumflex arteries?
Yes, while mobilizing, yes, sir, during mobilization of the urethra, we cut the circumferential arteries, sir.
Circumflex arteries, not circumferential arteries. Second is bulbourethral artery. Third artery that you can cut accidentally or by design. So these are the questions that should come straight away. You should not be waiting for answers.
The common penile arteries.
Common penile artery, dorsal penile artery.
Dorsal penile artery.
What are the branches of internal pudendal artery?
Sir, internal pudendal artery will give, sir, the first branch will be the common penile artery, which will divide into bulbourethral artery, the cavernosal artery, and the dorsal penile artery.
Are you correct? Only one artery.
So, common.
Any other person? Ram, Kasim. Anyway, what is the difference between a patient with a hypospadias and a normal patient when you are doing a PFUDD?
Sir, we should see in a hypospadias, if the bulbourethral artery has been damaged, the retrograde flow is already damaged. So there is a chances of ischemia at the repair site, sir. So there will be more.
What precaution you will take?
Sir, we will try to preserve the dorsal penile artery in this case.
You will always preserve dorsal penile artery.
Yes.
In case of a hypospadias, you should try to preserve at least one bulbourethral artery.
Yes.
One side mobilization, and you should preserve at least one bulbourethral artery in case of a hypospadias. Okay, now what are the reasons of failure? Means how you assess that you have reached the site of stricture, means the proximal limit.
So by doing yes, sir, by doing a retrograde or antegrade scopy, we can do, sir.
No. You are describing, you are mobilizing the penile and the bulbourethra.
Yes,
so how you know that now you have reached the proximal, the most proximal extent of your stricture? You don't need to dissect anymore.
Sir, as you told, sir, if you are passing or nail cath, that distal margin will not be able to pass through the stricture end. That will be the proximal end of the.
Should you pass a nail cath and feel for the tip? If you are reaching the tip, means you have reached the proximal. Or you can pass a small dilator 10 French and you can rotate it laterally and feel the tip. If you are able to feel the tip, means you have reached the tip.
Yes.
And now suppose you are pushing a antegrade boogie and not able to find the bladder neck. What else you can do now? 1, 2, 3. 1 and 2.
So first we'll see whether the SPC is in the midline or not.
Yes. If it is not in the midline, you would not take the patient in office. If it is in the midline, you are not able to pass it. What other steps? What are the things that you can do?
Flexible cystoscopy, sir.
Yes, flexible cystoscopy, or at times even you can use a male dilator, which can generally pass from a low pubic, low SPC tract. Okay. Any more questions, sir? Bakshi sir and Sarkar sir, you can ask.
Just one thing I would like to ask is, what are the things you should see while doing a antegrade scopy before proceeding for a urethroplasty?
Sir,
1, 2, 3.
Sir, we should first see the verumentinum, sir.
Before verumentinum.
Before
that. Bladder neck.
Okay, how does a normal bladder neck look?
It is a closed, sir. Initially, it's a closed.
Is it closed or something else? How does a normal bladder neck look? It's funnel shaped with mucosal rugosities with pink mucosa, and if you distend the bladder, you should open up. Sometimes you will find even with distension of bladder is not opening up, or you might find a scarred bladder neck, or you might find if there is some anterior injury, the posterior half of the bladder neck is normal, but the anterior half of the bladder is scarred. So I think this patient is having a scarred bladder. And if you find a scarred, fixed, open bladder neck, this patient may be incontinent post-operatively. You have to explain to the patient regarding this. Okay. That is the reason. Second thing you do during antegrade scopy. Anything else? You look for any stones.
ঠিক আছে চলো ঠিক আছে দুদা কাল চড়ে পরশু বারবার পরের বার চড়ে দেবো
Ranjan da mute.
Oh, আমার ব্যাগ
Ranjan da mute.
Deepu, if you don't have a flexible cystoscope, then what else you can do? If you are not able to pass the retrograde antegrade.
Rather than for scopy, you can use a urethral scope also, sir.
Now you have started imagining.
কোথায় গাড়ি তোর বাড়ি?
Sir, you have to if you don't have a scope, a flexible scope, if you are not able to pass a boogie, then best is to open it. You can't do it with a scope. Anyway, why that antigrade? What is the name of that antigrade?
না এইসব পড়েছি লঙ্কা কোনোদিনও লাগাবে
Hegrove staff.
লঙ্কাটা ডিরুট
What is the
আপরুট করে
color?
দেয় লঙ্কাটা আপরুট
What is the color of Hegrove staff?
Dark brown, sir.
দেবাংশু আমি তো দেখছি
Black. Why is it dark black?
Why it is black?
হ্যাঁ ও
Why the
আচ্ছা
instruments of urethroplasty are black? Generally, all the instruments are black.
Because we are using a focused light, so it should not shine while we are.
Yes, we are using a focus light. And
Okay,
what are the sutures that you use for urethroplasty? What are the various sutures you know of that can be used?
Sir, I have seen mostly using 40 Vicryl or 30 Vicryl. PDS can be used, sir. PDS can be used.
Suture, Vicryl or PDS. These are the.
Yes, sir.
One thing, Dr. Deepu, is how do you prevent entanglement of the catheter while you suture, while you approximate both the ends?
So first I will try to do the posterior part like 6 o'clock, 4 o'clock and 8 o'clock. Then I will pass a catheter. Then and then I will tie the 12 o'clock, 2 o'clock and 10 o'clock positions.
And during this, what will your assistants do?
We'll keep the straight all the ends of the sutures away from the
all the sutures should be kept taut so that there is no entanglement. Any other method you know of you can do?
For
in CMC, I've never seen, but heard that they do not put the catheter. They just do the anastomosis and after that they put the catheter.
Yeah.
Yes, that is.
Ganesh sir does
Quite
this.
a-
Ganesh sir
Ganesh sir
always.
does.
Ganesh sir does
Many-
first. One thing I want to tell Dr. Deepu
yes, sir.
that the sutures on the right side and left side to be separated. Actually, how it can be done is that 3 sutures on the right side and 3 sutures on the left side. We put it in the artery forceps both ends, and that will be that 3 sutures will be put on the over a Ellis tissue forceps. Okay, one side. 3 within the handle of this thing will be put in the Ellis tissue forceps, and 3 on the other side on Ellis tissue forceps. Okay, so one by one, then you come to know. Otherwise, all will be entangled. It is very difficult to identify each and every sutures.
Yes, sir. We can also use a straight for a center one and a curve artery forceps for the.
Yeah, this is good. This is okay. But if you separate out 3 on Ellis tissue forceps, one by one side you do, then you free the one side, then you anastomosis, you tie the other sides after putting the catheter.
Okay, I think this is enough for the examination part. In other parts they can read. So so if I am to summarize today's cases, the first thing is the resident should be very careful while taking history. In case of anteurethral stricture and PFUDD, they should write down what are the histories they should take, as Dr. Upadhyay has nicely depicted in his presentation. And before exam, you should you should jot down all the points you should ask, all the things you should see. And while you are examining patients before exam and day-to-day life, you do it in that fashion so that you do not miss any points. And you should know everything about RGU MCU. You cannot do any mistake in the positions, the concentration, why you need a dynamic, what are the things you should see in RGU, what are the things you see in MCU. And during operation, you should know what are the basic steps, why you should do antegrade and retrograde scope, what are the things you should see, and the steps. This is all in case of PFUI. And in case of buccal mucosa, you need to know why the buccal mucosa is of choice, what are the other options you have, what are the steps, and what are the different types of BMG urethroplasty, and if it fails, what are the options. DVIU is a very simple, but sometimes it's given in exam. What are the steps, what are the things you should see, and how to prognosticate a case of DVIU That is very important. If you get a case of DVIU, you'll surely ask these questions. How do you prognosticate? And anything else, Dr. Bakshi, Dr. Upadhyay, Dr. Maji, sir? Anything else they should know?
My sincere advice to all MCS and DNB students that you please read the Campbell's urethral strictures procedure. What is the urethral stricture subject? And everything is written there. Just you read once, twice, and Bendy's textbook of this thing, urethral surgery. There's another. You will come to know many things about the PFUDD as well as urethral stricture disease.
Maji sir, you want to say anything?
I think instruments are very for urethral surgery. Student will be accustomed to get knowledge about different type of instrument required. As already Suchas meter has been discussed, the instrument of the
Okay. May I now request Dr. Vijay Kumar and Dr. Kollan Sharkar to share their views regarding this class?
I think Bachi sir has got few videos to show. Bachi sir, you have few videos to show?
Is it time is there to show?
Actually,
time is
from the office, they are saying time is short. Maybe you can show one video of your choice.
If you have a video of a tissue flap, I think.
I don't have any tissue flap video. Already we have discussed PFUDD, these things. These videos I have, as well as I have video for that urethricuteness, or that is your Kulkarni technique. If you want to see Kulkarni technique again.
No, you have already shown that. Anything
yeah, I have shown.
Instruments, I think, will be discussed after some time.
The
There is a
separate
separate
class.
class for instruments.
Okay, then let's call it a day. So we'd like to hear the comments from Dr. Vijay Kumar and Dr. Kollan Sharkar. Can you hear us, sir? Dr. Kollan Sharkar, sir?
Yes, I can certainly hear everyone, and I've been intently listening to the program. I think the subjects were very widely covered, and obviously there are many other questions which were not discussed today, which may be brought out.
hampered.
And so a lot of things may be asked in the questions which have not in the books and not been discussed today. And I think the most important thing about urethral stricture surgery is for everyone to understand that there are actually no guidelines. You know, if you look at the various guidelines available, including the Indian Journal of Urology, the SIU, USI, the AUA, and this sort of guideline, and the EAU, if you look at them, everyone, there is a lot of controversy, and there's no level 1 evidence for most procedures. So I think I think one must apply common sense, and what is sensible to know is that you need to diagnose urethral strictures properly. You need to counsel the patient that contrary to a prostate surgery, urethral surgery patients, urethral stricture patients will have a problem. Like John Blandy said famously in his article in 1980 in Postgraduate Medical Journal, he said, once a stricture, always a stricture. And so that is something that I think everyone should keep in mind. And regarding, you know, there are no papers with true long-term follow-ups of stricture. Even the longest follow-ups of BMG urethroplasty, even in the hands of a person as an expert like Tony Mundy, he records a significant failure rate. So the point I was trying to make is that in the exam, use your common sense. I think the examiner wants to know that you have handled enough cases of urethral stricture. You've seen them in outpatients. You can recognize the symptoms. You can investigate them properly. You know how to do an ascending urethrogram personally. You know how to do an MCU. You understand the symptomatology of urethral strictures, and then handling it, of course, there are so many options. And I think learn 1 or 2 procedures, learn the DVIU procedure, and and the Kulkarni procedure or the Barbagli-Kulkarni procedures in details, because there is a lot of application in our Indian patients with lichen sclerosis. And also learn the techniques of anastomotic urethroplasty, which has been so brilliantly discussed today, both by, and these techniques have been demonstrated by everyone, Pushkal and Rohit, and my good friend Taposh, with Professor Taposh. So I think they've been very nicely discussed. So I have nothing more to add. So just, and as I think the bottom line again, this exam is based on Campbell's. So go through Campbell's, but just go through Campbell's, but also read a few of the contemporary guidelines which have come up. You know, all the societies have brought out guidelines for urethral strictures in the last 2 or 3 years. So read them. So that is all. I think this was a fantastic meeting. I think very well done, especially, you know, all the case discussions and the operative summaries were very nice indeed. So thank you everyone for making this meeting a success. And good Ranjan, I'm not sure if the chairperson is here. Is he here? Probably not.
Yes, sir.
Yeah,
yes,
Vijay.
yes.
Vijay, Vijay, would you like to make some comments, please? We missed you. Please unmute yourself, Vijay.
Yeah. Hello, sir. Good evening. Hello.
Yes, sir. We are hearing you.
At the outset, I would like to thank Bengal Urethral Society, our president, Dr. Kalyan Sarkar, and our secretary, Dr. Ranjan Dey, for organizing this lecture series and teaching program for the PGs. It has been very informative. But one thing I would like to stress to the PG students that in examinations, they are usually supposed to know the basics of all investigation, what are the prerequisites, what are the likely complication, and how they should perform the investigations. They may be asked, because as in first case, someone has noted that in the clinical finding there was induration of the distal penile urethra. Induration means infection or some sort of inflammatory process there. So I think it would have been wise to clarify it and to avoid ureterogram for some time till infection subsides, or diverting supraabdominal cystostomy could have been done, because the examiners want to give the society a safe surgeon. Everyone who is doing an MCH are known to have basic knowledge, basic training, and they are supposed they are learning surgery is a lifelong process. We are still learning even after my retirement, and everyone is improving day by day. But basic principles should not be omitted. Otherwise, it has been a very nice program, well covered. Especially Dr. Bakshi and Dr. Rohit has done a very tremendously good job. Thank you. Thank you all.
Thank you, sir.
Thank you, sir.
Hello.
Yeah.
Devanshu, is it, have you completed the session? Devanshu?
Yes, I think it's been completed.
Yeah, you have completed the session. One of the most wonderful session I have presented throughout in this series. We are almost at the end stage of the program, in the sense it's a months-long program, 2.5 months it has gone, and we have only one more weekend left after tomorrow. So we must understand how much effort the teachers have given, how much involved the students are there. And today's program, it was so extensive, even I did not know many answer what was asked to the students. So I am really grateful to the teachers. I am grateful to our moderator, Dr. Devanshu, for organizing such a brilliant session with the help of our very efficient and the interested and enthusiastic teachers like Rohit, Pushkal, and my friend Dr. Taposh Majhi. All of them have done so well for the benefit of the student. I am really, really grateful to all of you. And with this, I must express my sincere gratitude to our president also to be present for the entire session, for all the days, for the last 2.5 months, and also his valuable comments for the students. But I have a small input for the students only, though most of them have left, I can see because I am watching all this, that in the examination you will have to answer the basic things more precisely, more effectively, instead of going for 10 types of methods, 10 types of procedures. You must know one procedure in depth, and that should you know, so that any question which can be generated on that issue should be able to answer. So my friends and my students, don't get afraid, that I can assure that all of you have studied enough, and in the near future you will be our colleague and you will do a very good job in practical life also. With this, I welcome you once again in advance for the tomorrow's program of the instruments and imaging, which I believe all of you will enjoy. And with this, I thank all of you and welcome for the tomorrow's program. Thank you. Good night.
Thank you.
Thank you, sir.
Thank you.
Good night, everyone. Good night.
Good night.